So everybody, welcome to Think Out, the monthly debate series of the Institute of Science and Technology for Humanity at Nanyang Technological University in Singapore. So at the Institute of Science and Technology for Humanity, we address societal challenges through transdisciplinary team research. We're combining the latest in science and engineering with deep domain knowledge from social science, humanities, business, and arts. In each Think Out, two of the Institute's leading researchers, in this case May and Joseph, both from very different disciplinary backgrounds, will debate an important question the world is facing. In a Think Out, we aim to dive deep into a complex issue, have fun, and engage you, the audience, in this friendly battle between leading thinkers. Today, we address the question on how digital assistants can contribute to promoting health and well-being. My name is Vanessa Evers, and together with my colleague Hallam Stevens, we will moderate this debate. So over to you, Hallam, to introduce our research fellows for today.
Thanks very much, Vanessa. Welcome, everyone. So I'm going to introduce May and Joseph properly in a minute, but I just want to say how we intend to run this session. Basically, our format is to give each of the debaters about 5 to 7 minutes to introduce their research and their kind of position on the topic under consideration. So digital assistants today. They will begin to do that in a minute. We want this session to be as interactive as possible. We want it to be a debate not only between Joseph and May, but to bring all of you into the discussion. And you can do that by posting questions and comments in the Q&A function. And Vanessa and I will kind of moderate those and read them out as appropriate. Please do follow up with further questions if you have them. Don't just post your question and leave it. If we haven't answered it, feel free to come back at us. Do feel free to post comments as well. So we want this to be as interactive as possible. Another mode of interaction is we have a poll question at the beginning and at the end. So perhaps we could post that now to kind of judge people's opinions from the audience and whether they've actually changed. So hopefully that will pop up in a minute. There it is. You can see it right there. So do respond. As I said, we'll do this at the end as well and see if people's opinions have actually changed. So let me introduce both May and Joseph. I think what we're going to do is Joseph's going to go first. So let me introduce him first. So Joseph is an associate professor at the Lee Kong Chan School of Medicine at NTU. He's a physician and a scientist with an MD and a PhD with many years of research and clinical experience. He's the founding director of the Center for Population Health Science at the medical school. He's the chair of the Health Services and Outcomes Research Program. And he's also the director of the Global eHealth Unit at Imperial College London. He's worked also with a range of global health organizations, and he is currently the director of the World Health Organization Collaborating Center for Digital Health. May Nguyen is a professor at the Wee Kim Wee School of Communication and Information at NTU. She's the director of our University Scholars Program. Her work focuses on health and strategic communication. She's worked on developing multiple mobile phone-based apps and systems for combating and tracking diseases, including dengue. Her research has been widely recognized through numerous grants and awards, including the Raffelsian Award, the Ogilvy Foundation Award, Fulbright Award, and in 2019, the Outstanding Applied Researcher Award from the International Communications Association. So you can see two very distinguished scholars, and I'll invite Joseph to go first and present his work. Thanks, Joseph.
Thank you, Vanessa. Thank you, Hallam. And thank you all for joining today's conversation. I can't see you, but if I did, I would smile. I might look at your eyes and try to create an eye contact with you. So I'm now only hoping that we can approximate this And actually this initial point about approximation leads me nicely to the conversation about the health assistants. Lots of this is about approximation, about getting as close as possible to the real thing, to the physician, to the nurse, to another healthcare professional. Now, as I've been presented very nicely by Hallam, I don't think there's much more to add about my positions, but maybe just to share a little bit about my passions. And I really want to say, number one, that when a physician goes into medicine and when you decide to go into science, it's like with all of us, we want to make a difference. We want to make a difference with our work, with our research, with our care for people we look after. And the area where I'm contributing and hoping to make a difference is in digital health. Digital health is very broad. There are many things that fall under it. And in fact, is the field of research which is very intertwined with health systems. So if you are a digital health researcher, if you're good, you're also a health systems researcher, and that's what I'm trying to be. Now, more specifically, I'll just highlight 3 points and we can come later in more detail to those. Number one, we are looking really how health apps and what is increasingly called as digital therapeutics or digital diagnostics, etc., could make a difference, support people in achieving better health, support healthcare professionals to achieving better healthcare delivery, and so on. So that's number one. Number two, we've seen the transformation of the world in terms of digital technologies in the last year from the pandemic. And not all is bad. We've experienced how much we can achieve by working remotely, by not going to our office or to our work physically. In fact, research suggests that across the board, there is a 10% rise in productivity if you work remotely. Now, that's a huge improvement. Now imagine if there was an assistant helping a doctor and achieved an improvement of 10% in doctor's productivity. And maybe not just productivity, but my accuracy when I make a decision, whether that's a decision on different aspects of care, that would be massive. And just briefly, 2 more points. One is we focus on digital education as well, and we see opportunity how digital technologies, whether it's through virtual reality, virtual patients, serious games, but then also things which we may see more mundane, like just online learning or m-learning, can make a difference. And finally, this all is being packaged into, as I said earlier, health systems and population health research. And I'll pause there, and I look forward to hopefully interacting a bit with you. Yeah.
Thanks, Joseph. Great intro to you as well. May, did you want to start your introduction?
Yes. Hello, and thank you very much, Vanessa and Helen, for inviting me to this talk. I look forward very much to sharing perspectives and having a discussion on this very important topic. And I must say that over the past year, many of us have been involved in talks and different types of virtual lectures. And, for us academics, a lot of teaching online that's gone on too, but it's often difficult to have spaces for conversations. So that's, so I really kind of welcome the format. I think, Helen went through this kind of a discussive format rather than a debate, but, it really, I think that the opportunity to share and converse, just to talk, right, to have discourse is very welcome. And I just want to do a little quick intro about my research work in digital health. I kind of fell into it almost by accident because I come from the field of health communication. And oftentimes we try to look at strategic ways and channels that communication can be effective, right, in influencing population behaviors and so on. And, about 12 years ago, I had the opportunity via a large grant to do groundwork in various parts of Asia. And when we went to these different countries, you know, it just happened that this was when the wave of the mobile phones in these countries were taking off. So these were not countries that had a long history of technology, nor populations that, you know, were able to buy the latest and the smartest handphones. But people were just buying and starting to use handphones. I mean, nowadays, like if you go even to the, you know, most rural areas of Myanmar, or if you went to, you know, even the poorest areas of many of the Asian cities, you would see the mobile phones being used. So we realized that there was a lot of potential in that. And that's how, you know, my forays into digital health started. And if I could just share the screen, I have a really quick summary of the type of work that I have been involved in. Please just give me a sec. Can you see the slide? This one slide on my work. You might see two slides or something like that, but
yeah, exactly. It's on presenter view.
Okay, that's, yeah, it's the just wanted to share a little bit of work in the digital health space. And you know, on the right side are the works that I've been doing in many parts of Asia. And I think that Helen mentioned dengue and vector work that's, you know, to battle the problem with mosquitoes. So been doing work in Sri Lanka, again, you know, riding on that wave of the mobile phones, trying to show the hotspots and trying to drive populations to, you know, clear the water retention areas and so on. And the interesting thing was that because of the limitations of you know, what technology can do, this type of technology was not so usable for high-rise places like Singapore, because it used this kind of mapping. And in Singapore, of course, if you map and you've got a building that has, you know, lots of mosquitoes, we don't know which floor it comes from, right? So we took the ideas as well as the concepts to apply it to influenza in Singapore. And, you know, that again, coming on the wave of past SARS and other experience in Singapore, we've been doing projects like Flu Mob and Flu Tech with Tan Tock Seng Hospital. And now we are going to be rolling out COVID Tech for university communities. So starting in a couple of residential halls in NTU. So it's all about data analytics, crowdsourcing, and so on. But on the other side, I have, when I say the other side, it's the non-infectious disease side. I've been involved in promoting health and well-being using a lot of social robots. So here on the top left-hand corner, some of the robots that we're using to drive kids to do exercise and, you know, eat more healthily. And a program called Pet Fitness, where students in Singapore schools adopt virtual pets, and then the pet becomes a conduit to drive certain types of behaviors as well. So just wanted to share that. And so, you know, so my perspectives are very multidisciplinary. I come from the communication field, but have a, you know, a little bit of links in the from the business perspective, as well as, of course, very much grounded in the humanities and the liberal arts as well. So over to you, Helen. I'll just stop sharing this. Thank you.
Thanks. Great. Thanks for both those summaries. So I mean, I think that, you know, you've presented kind of where, in some ways, things about kind of thinking about where we're at, and maybe, you know, to ask you maybe a question that's on people's minds, and to begin with, and a question about sort of where we're going here. I'm interested in how far do you see this kind of going in terms of, well, I guess even this being able to replace to some extent, you know, us going to a doctor and getting a diagnosis, right? To what extent do you see these kinds of digital assistants of various kinds actually, yeah, displacing the kind of doctor's visit that we have? Maybe Joseph, I'll ask you to respond first, and then Mei Luen, if you have anything to add.
Okay, thank you. It's a great question, and I'll start first with an analogy. And rather than my own personal experience, I'll share from a couple of colleagues. Oncological surgeon from US, a friend, is telling me, you know, before the COVID started, he saw all of his patients face-to-face in person, obviously. He said now he sees more than 50% of them online, virtually. He said, I could not imagine anywhere close to get to 50%. And now they are redesigning the whole clinic and saying, actually, we start to see even advantages of this because we can see patients more flexibly and they can, without taking a full consultation, keep us updated and so on. So the same analogy it could be applied to healthcare assistants. You say, hey, I don't want to be seen by a machine. Yeah, I want to be seen by a doctor. But if we, and those who study medicine, and in fact, you will experience this even if you're a lay observer as a patient. Every consultation between a doctor and a patient has a certain structure. It's not always followed in the same order, but there are components to this. And so we can take some of these components immediately and ask machine to help us. The first part of this consultation is called medical history taking. So it's basically asking, how can I help you today? What's wrong? Oh, it hurts you here. For how long has it been hurting you, etc. These questions could have been asked by machine, and in fact, could have been asked by machine. I use the analogy machine or AI. Please advise me, those who are computer scientists, which is the best term. But very consistently, okay, maybe not with a smile on the face, but very reliably. And so that's one area where there could be help, and we could see immediately a bigger role for assistance in healthcare. Now, yeah. Please.
Sorry, Joseph, I just wanted to interrupt because, you make it sound like these virtual agents are super sophisticated, whereas, in my experience, they just suck. They don't look very good. They have a very clunky way of interacting with me. Are you considering a idealist future in this?
No, fantastic. I'm just, with my not physician, but with my scientist hat, I'm seeing a massive opportunity, for researchers to make a difference, to advance the practice of medicine, to advance the science of medicine. But you are right. Today's healthcare assistants are, we could have a long debate where we are today, but we are not very far, in terms of where the potential is and where we are today. So again, good news for scientists. I'll pause there because I could get give lots of more examples, but I'm really keen for May to give her perspective on this, and she's an expert, and yeah, looking forward, May.
Thank you, Joseph. I'm not sure whether we're supposed to disagree, but I certainly agree that the complementary and the supplementary to what a doctor does in order to enhance the efficacy, right, in a doctor-patient consultation is very much welcome. The possibilities that I see, and kind of to push the envelope a little bit further, is, I don't know whether we would call this almost like a binary in terms of how we see this whole space progressing. Because on the one hand, what you talk about, the doctor-patient conversations, the sophisticated technology that doctors nowadays use to scan the patients and so on, that seems to be the norm in, major Asian cities now. I mean, cities across the world, right? But there's a huge population of the world's population who don't have access to that type of healthcare and health systems. And, sometimes they need to walk 2 or 3 days in order to get to a very basic clinic. And I see the opportunities even more for, that part of the world's population, but not in the same way that it might be an assistance to the doctor, but to provide some basic health information, healthcare, and so on. So it's almost kind of like binary, because we see like the, very technologically advanced care systems and how, technology and especially AI would be coming to aid. But on the other hand, just basic digital health might be, can I say that, if we push the envelope, it might even change the way healthcare is being structured, right? To some parts of the poorer rural populations. I have some data from a study that we did at the end of 2017, 2018 in 10 countries, regarding kind of this kind of new initiatives. Would you like to see that? Can I share that?
Oh, sure, May.
Maybe,
Please share. Last time you shared, we saw it from the notes view, so you might want to just click the, what do you call it, the screen projector button. I don't know what it is.
The settings in the top left corner, you see you swap the option.
Yeah.
So while you're working on that, I'll try to put it together. So Joseph, you mentioned, there's stuff that could be done by a machine, which is true. And I was thinking maybe sometimes, May, you mentioned for some people, there may not be another opportunity, right? It may be a much more lower barrier way to access to healthcare. And I was also thinking for people that don't have all these barriers to healthcare, sometimes you might prefer not to have to tell or show something to a physician, but show to a machine, because it's just less, you feel less vulnerable, you feel less exposed, if there can be like a machine in between.
Excellent point, Vanessa. And actually, just to go back to May, it's very true. The opportunities where we have a huge shortage of healthcare workers, in fact, millions of healthcare workers around the world. Countries which are the most affluent, such as Switzerland, such as Singapore, are importing healthcare workers, both doctors and nurses. So this is, I'm giving those two countries and many others. US is one of the biggest importers of doctors. So there's complex reasons for this, but what I want to say is that we see low middle-income countries having a true massive shortage of healthcare workers. So it's not, oh, do I want machine or I want a doctor? It's, do I want nothing or anything? That's the first point. I think to go back to your point, Vanessa, about being more comfortable with a computer perhaps or AI. There is some research which shows very, very interesting data that in relation to mental health, in relation to sexual history, people are more open to computer than to a doctor. So if a doctor asks them about their past sexual history, oh no, none there. Then the machine asks them, they are able to disclose quite a few things. And what's most interesting here is that if you do this before the consultation with the computer first, and then they go and see the doctor, they're comfortable with doctors seeing this information from the screen, but not they speaking it out in front of the person. So this is just one example. Mental health, again, is a huge, we know that more than half of the people who have mental health problems which do require treatment. They are not mild, they are not something you can just ignore. Don't seek care. In fact, even when the doctor diagnoses them, I'll give you something striking. When pregnant women, they can rarely, well, not so rarely, but they can also get depressed. And when they are offered to seek treatment, and that treatment doesn't need to be medication, could be just counseling, more than half do not take up this offer. So there's a huge stigma related to this. And we are looking into, okay, would they accept at least some computer support, maybe computer CBT, cognitive behavioral therapy, and so on. So there's a big potential in that, and fantastic point, Vanessa. Thank you.
Thank you. I'm going to just try to share this. I'm not sure whether it works. Does it?
Yeah.
Oh, if you can see
it.
Yeah, it's okay if you see the others small ones on the side, but this one, yeah. Is that okay, Vanessa?
We can see it, yeah. I mean, we see everything around it. There, if you click there, we can probably, yeah.
No,
this one, is that?
That should do, oh.
Yeah, and now go to the top left corner. You have display settings.
Yes.
And choose, click, swap.
Ah, okay.
Now we see your slide.
Yes, yes. So this was a study that we did in 10 different countries. We had over 1,000 respondents from each of the countries, and it was really interesting to see how much people were already using the digital health that's on the left side in terms of animated, which includes virtual as well as the robotics, although not much. Most of this is online animation or chatbots and so on, as well as other new areas that are rising, like health forums and health bloggers. So it seems that this kind of especially in countries that don't have access to the type of healthcare that we see here in Singapore, it seems like this, there's a lot of activity now that's picking up in terms of the virtual efforts on health. Yeah, just wanted to share that to give us something to think about. Also, the differences between countries, right? And usually we would think that, oh, a country like Japan, they would be very technologically advanced, and therefore you would have a high number. It's actually very low, as opposed to some other countries here, like Thailand and so on, where there's new dependence on these
right. I guess if you have to go a long way to a doctor, or a doctor's not so available for some reason, then you have to be reliant on the technology, right?
Yes, that's certainly the case. But it also seems to be linked to what we call digital imagination, because can you imagine in some of these rural areas, the population did not have phones in the first place to be able to call a doctor and consult and so on. They didn't have access to TV, they didn't have access to any type of technology, and then suddenly they have the mobile phone and they can get health information, which is they may not have depended on that same. They're not kind of replacing the telephonics of the old, but they're just kind of imagining how I can benefit myself and my health, and they're looking at different types of links and tools to be able to do that. So it's almost kind of a restructuring of the whole way that we look at health, right? So typically it would be like you try to look for a healer, a doctor, somebody who can help you, a clinic and so on. But, so now like the way that people assess health and how they imagine how they can better their health, at least in the preventative front, seems to be evolving, which is kind of exciting. Yeah.
So I guess maybe we should say that we have one question in the chat so far, but perhaps we certainly now open if people who want to post comments or questions. But maybe I'll just kind of push this a little bit further. And I mean, Joseph, you used the example of collecting information, but I'm just wondering how far does this then go, or how far do you see the possibilities of this going, right? So you collect the information, and the first thing that you might do that is just report it to the doctor, right? The doctor just sees it. But then, I guess the next step might be something like, processing that information in some way so that it gives a kind of preliminary diagnosis, right? I mean, that maybe is the next step. And then maybe, the step far down the road is something like, well, you just, it already mails you the, it mails you the medicine, right?
That's right. That's right. You get it by post, the delivery. I like to use here analogy, those of you who had babies will know that as they get born, you don't give them steak, and we love steaks, sorry, if you're a vegetarian, apologies, vegetarian steak, if there is such a thing, but you feed them milk. So you take a stepwise approach. And another analogy that we always say is, you have to learn how to walk before you run. We don't see this in medicine. Booking appointment online rather than calling a receptionist. You can do it with a haircut, with the hairdresser for your haircut, but with a healthcare majority you still can't. You either have to phone them, or you have to go in person to book an appointment. Yes, it sounds surprising, but that's, and so there are small transactional things where we have opportunity to digitally, not just transform, but just to digitize the processes. And medicine is lagging behind other industries. I gave you one example. I could give you thousands of other examples. Why am I saying this? Because we, through each of these steps, we build confidence. We build something that you take it for granted, you take it as normal, that there is a digital component to that interaction. And so the ultimate goal of then having a computer which takes history and then starts offering differential diagnosis, to go directly rather than very broadly to your question, Hallam, is today, from taking the medical history, what the machine can already do is trawl through and analyze all the medical knowledge and then offer what we call, a medical term is differential diagnosis. So give you the choices, what might be, and even in the likelihood order, the possible reason for your problem, or it might recognize, actually, this is the next step. You need these and these investigations before you can conclude what it might be. You know, because you need to exclude this, or you need to exclude that, you need to confirm this, etc. So there's lots of logical reasoning in medical doctors' decision making. Yeah, and machines are good in replicating that. In fact, in being very much more consistent than we are. Sometimes there is intuition, you know, often in medicine, but even that can be, you know, with deep learning learned. Okay, does that answer your question, Hallam? I can go further. Yeah.
Yeah. Thanks. Maybe I'll invite May as well to,
yes, please.
To, you know, do you have any thoughts about this? How far could or should maybe this go? And maybe you have some insight into some of the problems that might arise even as we go down this kind of road, this stepwise kind of approach.
You know, there's certainly a lot of opportunities, but also potential unintended consequences. You know, so, you know, some of the opportunities I see as, you know, being really able to just save lives because of the speed at which a lot of diagnosis and so on can be done. I mean, just a simple example is that, you know, in many countries across Asia now, if you were to look at the, you know, vector problem, the mosquito problem, and you wanted to know whether you have dengue fever, you would have to go and get yourself tested, and very, you know, onerous process. And then after that, they've got to check your blood and so on, right? So if that can be just shortened, when the, you know, for instance, in many countries, again, we have these mobile healthcare clinics and so on. If they can do some kind of you know, blood taking, and then all the blood analysis and so on could be done maybe even by mobile phones, and it could be immediate, then the treatment could be given immediately, right? So saving like 4 or 5 days and so on. So I see those as being critical. But on the other hand, you know, such types of rapid diagnosis would require a lot of information to be taken, not at the hospital or some kind of a central place, but it could be somewhere on somebody's mobile phone and so on, right? So there's a lot of potential issues with data security and privacy. I mean, it is a completely, you know, different but a complex can of worms. And in you know, in some of the scholarly research on data and privacy and so on, there are researchers who have, you know, Professor Jerome Williams in Rutgers, he's published a lot of information about something called, you know, retail profiling. So and there's possibility that also is becomes embedded in healthcare systems. So what happens is that in retail profiling, the systems provide the retailer information such that they think that they can manage customer processes better through profiling the customers. It is not the right thing to do, but it helps in the efficiency of business systems. So for instance, if you go and put gas and you have a certain type of profile, you may not be allowed to swipe your credit card just on the spot. You have to go inside the gas station and pay. So they kind of differentiate, right, what the customer is able to do. It helps to manage, but there is actually a risk. There's a risk that, certain types of profiles will be, because they are shared prior to coming to the hospital and so on, may be directed to different queues and so on. So this kind of, potential unintended consequences is quite real and has to be considered very seriously by the governments and authorities, I feel.
Thanks, May. That's super interesting. I have so many questions actually in response to both of your comments, but we have a few questions in the Q&A, Hallam. Probably we should move over there since we may not have any time left if we're not careful.
Yes, right. So perhaps
maybe wait with we'll answer your question, Lee, from SUSS, because it's maybe a little bit more applied. We'll move to it next, right, Hallam?
Yeah. So I think there's a question here that sort of follows up on I think the direction that May was just talking about, and I guess this question is about kind of what might this change, this kind of structure of online medicine or digital medicine change in terms of the structure of healthcare, right? And in particular, I think maybe to sort of pick up on the point you were making, May, I wonder whether this has implications for the ways in which hospitals work or the ways in which insurance companies kind of operate, right? And, do we need to perhaps think through some of those kinds of consequences as well? And I think the question actually asks in particular whether this is kind of has the potential to exacerbate power disparities. And, I know that your work has certainly kind of touched on that. So maybe, I guess, again, this is about the kind of risks you see within the structure of the healthcare system, I guess.
So this, you're pulling in Ming Wei Ang's question here, Helen, right?
That's right. This is
I just wanted to add the anecdote that not an anecdote, but the nightmare scenario that she gives at the end to color that. So he or she mentions to imagine a kind of nightmare scenario where AI is used to determine whether someone is combat fit through health examination. I guess because this is someone who served in the national service in Singapore. Or are you allowed now as a woman to serve? I'm totally digressing, but okay, I'll stop here.
Did you want me to respond to that?
Yes, May, did you want to start first?
Yeah.
Okay, I was also looking at Lee's question from SUSS. So if I have time, I'll just jump back into that a little bit.
Yeah,
Ming Wei Ang, so your name's Ming Wei? Yeah, Ming Wei, thanks very much for that question. Some of the nightmare scenarios have been played out in even in movies, for instance, right? And some of these movies like 10, 20, 30 years ago, and it was hard to imagine a pandemic like it is now, or, even the scenarios, but so that, we're facing, but we've seen some of that. So it looks like deja vu, right? It's like, oh no, we saw this scenario in this movie and so on. And I think regarding what you are saying, I don't remember the name of the movie. I remember this movie about, where the kind of the gene technology gets so advanced that all babies are given this type of test, and then they become categorized based on the capabilities identified at birth. And of course, this was a story about a young man who wanted to become an astronaut, and he wasn't in the category of, astronaut. And so he kind of like, tried to change a lot of things like his fingerprint and so on in order to be able to qualify to become an astronaut. And, and so that, and it was really kind of philosophical in the way that the questions were posed, right? As to whether, that kind of humanity, like your human nature and the grit and the passion that you have for something can overcome some of the biological, genetic traits that where this type of information may surface, and how do we kind of deal with that? It's fascinating, and I don't really know the answer to this in one way or the other, but one of the things that I would certainly, bring up is the need as we go forward with, data collection and, the technological advances and so on, to balance with, humanity, right? I mean, the humanistic needs as well. I mean, even when we are developing robotics, for instance, right? Is it all about facing the objectives, being able to be very quick in diagnosis, having the fastest brains and so on? But what about areas like compassion, empathy, being able to feel pain, and so on, which are all such important facets of humanity, right? And so, so to me, I think that as we kind of develop, on this frontier, there is a need to balance with what we know and treasure about our human experiences.
Yeah. Joseph, I wonder if you want to add to this, since you are very active in bodies like the World Health Organization, these kind of political implications that might come up.
Yeah, so there are complexities with every progress and innovation. And the best examples we see in the digital giants, whether it's a Google or Apple and all the Facebook, etc. They know massive amounts about us, and somehow, consciously, subconsciously, we accept this. Could this have implications, negative implications on people? There are examples where it does, on employment prospects for people. They check person's Facebook profile before they employ them and say, no way, you're not going to be with us. And so we need to be just consistent in that sense, that healthcare, these concerns are real, but they are not exclusive to healthcare, and they are not exclusive to our personal information in the domain of health. There are many other aspects of personal information about us that we feel equally strongly about. And I feel that that's the discourse that needs to happen in the public eye. And if you want, we all need to become more digitally literate. And I think a good example was from the discussions we saw from US, Senate and so on, where it's very clear that the lawmakers are playing what, maybe playing is not the right word, but you will understand what I mean, a catch-up game with these big companies. It's a challenge of innovation that at the moment, it feels like innovators are always at least 2 steps, if not 5 steps ahead of the legislators. Can we change that? We must strive. And sometimes this will be very light touch regulation, which is in the interest of industry, because regulation does not mean always that you're slowing down the business. Quite the opposite. It can accelerate. I'll give an example. Germany has introduced, first in the world, digital prescriptions, which go further than what FDA did for US. It's very congratulatory how they recognize that medicine is a highly regulated industry, if you want, or sphere of human activity, and that the regulation is about trust, is about agreements, how we want it to be. So I'll stop there, but this is a big topic and should not be underestimated. In fact, we need a lot more research, discussion, education, legislation, policy on this.
Yeah. So Helen, do you think Lee's been waiting for so long for us to address his question. We should definitely start addressing
Sure.
it.
Yeah.
So the question is, it's really about the applicability and the possibilities of using AI or digital assistants or, you know, all that kind of technology for preventing or assisting for a heart attack or a stroke. What are your thoughts on that? I mean, how far is the technology to do that? I know that you know, there's these very simple rules that came out of triage. It's like a 5-point scale, and it helped much better for doctors to say, okay, this person needs to go to ER, that person doesn't, and you know, that kind of automated process led to much more accuracy. Is there something similar when it comes to heart attacks or strokes?
Yeah. Okay, I'll attempt to answer this a little bit, Lee. I serve on the board of Singapore Heart Foundation, and the board has many dedicated, you know, doctors and nutritionists and so on, who are all very interested in the issues of heart, which is, of course, one of the major killers in Singapore. And I know that the researchers there, together with the Singapore Heart Center, you know, Professor Terence Lee, who leads it, they are trying to work on two fronts. One is like amongst the population to identify, you know, who's at the who has a potential risk for heart disease and possibly stroke and so on, by identifying blood pressure and so on early. So you know, so they're doing a lot of work to make sure that the entire population gets screening and so on, right? So that's on the preventative front. And then they also have, you know, some very novel types of research that's coming up on the on I guess individuals who've been identified as having had like mild strokes and so on, and are at risk of getting a major heart attack. And that involves some kind of, you know, and Joseph, you probably know the right terminology for this, but some kind of, you know, small device that goes into the heart, and it's used for monitoring. And so what they have been trying to do now is to make it really easy for 24-hour monitoring, is to link it to the mobile phone, so that, you know, the circle of caregivers around this, you know, individual will then be able to say, hey, you know, it looks like, you know, dad is really stressed, and, you know, his heart rate is now seems to be going up and so on. So they would be able to do that. But of course, this requires that the patient has already been identified as high risk. But the more screening that's done, the more knowledge there is about, you know, blood pressure and so on, there will be, you know, a greater propensity to be prepared for any potential heart attacks. Yeah, Joseph, yeah, over to you.
No, I think you described it fantastically. You know, the device is pacemaker, and I think in that sense, these are real threats. These are real concerns, and these are real. This is real progress in how we can support achieving better health outcomes. Going into specifics of this, because the medicine is so wide and the opportunities for digital innovation is so wide, the complexities of legislation it's not easy here. So hence, I think we need to be on a constant watch, have a body which reviews, which has a possibility to guide, to educate. I've experienced working with startups where you see that they are very, very lean. This is not their top priority, and we should support them in that and find ways to enable that innovation not being stifled, but at the same time not becoming a risk. And with power, often the risks of things going wrong rise. So,
yeah.
Thanks. Yeah. No, I think these questions of sort of legislation and how to kind of govern this are extremely important to how this whole thing fits together. So maybe at this time we're kind of coming towards the end here, and so I want to put the the poll question up again. In fact, at first, when we first did it, about 1/4 of people said they would see an AI doctor, and actually significantly about 40% were undecided. So that's interesting. We'll see if it changes. But maybe a question here from Professor Andy Prowl, who's one of our colleagues at NTU. Interesting question that might also bear on this. He says some people might not want to see an AI doctor because it has nothing to lose if it's wrong. So humans feel like they have kind of some responsibility to a patient. They're responsible for the outcomes. If that patient, got sicker, or the patient died, then the doctor would feel bad. That is not going to be true of a machine. And I wonder whether, is that a reason to worry about seeing an AI doctor? This kind of lack of kind of care, one might say, lack of emotion perhaps, or even lack of accountability and responsibility. So maybe Joseph will ask.
They just don't have skin in the game.
No skin in the game, literally.
Okay, first thing about the skin in the game. Actually, it's much bigger. It's much bigger because they're typically, to develop such AI doctor, let's call it AI doctor, it takes a major investment, and they are insured the same way as doctors are insured for medical errors. To be human is to err, and to be a machine is not to make mistakes. Sorry, don't quote me on that. But that's the idea of a machine, it's a digital, it's binary. More specifically, emotions and care and showing loving and heart and all of this. This is more complex, and I will not pretend that a smiley face can replace a doctor's genuine concern. Let's just call it this way, or the trust. Having said this, we all have big trust in many aspects where machines support our life. And this is expanding ever greater. We entrust, with smart homes to machines that they will put the heater on and off, and lights on and off, and so many other things. Autonomous cars, we put, why wouldn't this autonomous car just kill us? Sorry, but, drive into, or someone else. So these same principles apply to healthcare. And these dilemmas. How far do we? But the future, for me, is very much about the symbiosis, and that's the word that I see as working between the AI and the human doctor, where this is my assistant and the patient's assistant, helping us that we together achieve better outcome. Thank you.
Agreed. Yes, very much.
May, do you want a chance to respond to that too? Yeah.
Yeah, thanks for that question, Andy. Andy's from my school, and he's a great colleague. Yeah. The issues of whether you would choose to go to an AI doctor in countries like Singapore, that's something that would be influenced by issues such as trust and credibility, the type of organization that's behind the AI doctor and so on. I think similar to what Joseph said, in a place like Singapore, it should be achievable to set up some kind of a mechanism that allows that particular sector to be regulated, to have an overview, and to to really have an oversight, right? I mean, I've been doing some work in novel foods, for instance, and that's one of the areas where the government feels that it's very important for the consumers and the public to understand what they are ingesting, what they're putting into their bodies, and so some oversight is needed. And so they've set up, these regulatory bodies which are going to make sure that new types of food products are going to be under certain types of strict regulation. And so if you have, and this is kind of, where there are trust conduits, right? If you believe that certain organizations or certain types of doctors, because they are part of the Singapore landscape, and they are structured in Singapore, and they are trustworthy, and we could go to those doctors, then I think that the public will have more propensity to go to the AI doctor. But if you just say that it's something that you see online, you don't know where they are based, they'll just give their answers and then run away, then of course there's likelihood of going to that doctor. Yeah. So I think that whole infrastructure is not even being mounted yet. It's very, very early days yet. But I think when all those components are in place, it'll be interesting to see how Singapore approaches this landscape as well.
Yeah. So I think thank you. I mean, I think we've covered a great deal of ground here, right? About the kind of what these assistants might do themselves, about kind of regulation, about issues of privacy, about issues of kind of care and emotion and accountability. And I think we can begin to get a sense of how complex some of these issues are when it comes to something like medical care. And I'm sure we're going to kind of see these debates kind of go on for a long time. In terms of our poll, I think the results haven't changed that much from the beginning. Interestingly, I think slightly fewer people said that they would want to see an AI doctor. So maybe we've put a few people off, but we may also be within the margin of error of our poll system here, I think. So, so at that note, I think we're pretty much at the end of our time, and I'll hand it over to Vanessa for some closing comments.
Yeah, thanks, Alan. It's true that it's about the same amount of people that are willing to see an AI doctor, but there's actually quite a few more that have now turned towards negative. So it looks like we've had a little bit more of a cautious tale today. This was a wonderful discussion. Thank you so much. We're left with so many questions. One question left is, for instance, do we have the digital talent available in Singapore for this? I'm still wondering about this thing of like, is it that AI is just for like poor people who have to walk far to a doctor? It seems so unfair. Like, you don't deserve a real person, we'll just give you AI. Inequality seems a big issue. What about combining medical disciplines? I mean, how come that medics don't work together as well, and what could role? I mean, there are many discussions. We should have another 4 hours, but we're going to stop here. That brings us to the end of our Think Out debate. Many thanks to May Olwin. You are an expert in assessing the impact of media and communication on physical activity and food and nutrition literacy among Asian families. And Joseph Carr, specialized in digital transformation of health and healthcare, population health, and health system science. So you're going to receive our super famous NIST Think Out water bottle. It is coming your way. The audience, thank you so much for your participation. Please follow us on internet, Facebook, and Twitter to learn more about this debate series, and especially to access papers and more information on both of today's speakers. So please join us for next month's debate, which is the 17th of February, on the topic of misinformation and trust in science related to COVID-19. Thank you very much all. Thank you, May. Thank you, Joseph.
Thank you.
Thank you all. Thank you.
Bye now. Bye.
Bye. Bye.